soal suara 1, 2, 3.
Bismillahirrahmanirrahim. I humbly ask all participants to switch off or turn their mobile devices to silent mode throughout the event as to not interrupt the ongoing session. I also like to give a soft reminder and then we thank you in advance for your cooperation. Bismillahirrahmanirrahim. Brigadier Datuk Dr. Osman bin Rahman, Commanding Officer of Tengku Nizam. Our valued speakers, esteemed guests, specialists of Tengku Nizam, member of the board, medical officer, and all level of staff present here today. Assalamualaikum warahmatullahi wabarakatuh and salam sejahtera. It is with a great pleasure and obedience that I thank the Almighty for giving us the chance to gather here today for this occasion. I humbly welcome Brigadier General Dr. Sharifah Azlin Juliana binti Said Zainal, Chairperson of Tengku Nizam Infection Control Unit to deliver her opening speech.
Thank you, Dr. Aina. Bismillahirrahmanirrahim. Yang berbahagia Tuan Pemerintah, Brigadier Jeneral Datuk Dr. Osman bin Abdul Rahman. Yang saya hormati Dr. Leong Chilun, Pakar Perubatan dan Penyakit Berjangkit Hospital Kuala Lumpur. Yang saya hormati Dr. Syam Hanif yang masih belum sampai. Dia awal adalah Ketua Jabatan Farmasi di Hospital Sungai Buloh. Yang saya hormati pakar-pakar, tuan-tuan, puan-puan hadirin sekalian. Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Syukur Alhamdulillah, all praises to Allah, the Almighty. Salawat dan salam ke atas junjungan besar Nabi Muhammad SAW. Peace be upon him. Now, since the end of 2019, we have planned for Nizam to start on forming an antimicrobial stewardship team. If you all remember, those who attended Prof. Sashila's lecture at the end of 2019, we really wanted to start the ball rolling. Unfortunately, much of our attention has been diverted into COVID. So we really hope finally that we're here, we are able to get the ball rolling again. My deepest thanks to Dr. Leong for coming today. For the past 2 years, I think Dr. Leong has helped us so much along with the other ID physicians. We all know that we don't have an ID physician in the hospital. And Dr. Leong has been entertaining my calls even late night. Thank you so much, Dr. Leong, for your patience with me. So he's been a key person in helping out a lot of crises in the middle of the night. Even Dr. Farah also had to call you many times. So thank you so much. We know the threat of antimicrobial resistance, and so I'm proud to say that we have recently formed an antimicrobial stewardship team that is headed by our able Colonel Dr. Nur Ashikin from JPT. We wish you all the best, Shikin. We know you can do it. So the team is formed by a leader from the medical team alongside with the representatives from all the other clinical departments. Including the IT, Encik Fahmi, our microbiologist, and the pharmacy. Okay. My heartfelt thanks to the speakers, and also I must commend my team, the Unit Kawalan Jangkitan, the pillars of UKJ, Matron Farida, Staff Nurse Marini, and Sergeant Junaida, who's basically been of great help. Thank you so much for helping UKJ. We are basically, it's been a steep learning curve for UKJ in this hospital. And I'm happy to say that they have done a very good job. We look forward to a very fruitful day of gaining good knowledge and fruitful discussion. And last but not least, thank you very much everyone for participating in today's session. May Allah bless you. Assalamualaikum warahmatullahi wabarakatuh.
Okay, thank you, Dr. Thank you, Brigadier General Dr. Sharifah Azim, for your kind words. Without further ado, we'd like to invite Dr. Leong Chi Lun, Consultant Infectious Disease Specialist from Hospital Kuala Lumpur, to deliver his speech titled The Challenges of Antimicrobial Stewardship. Before that, I would like to take this opportunity to introduce few details about our speakers. He was born in 20th November 1967 and was married with 3 children. Dr. Lee is currently Consultant General Physician and Infectious Disease in Infectious Disease Unit, Medical Department Hospital Kuala Lumpur. He first received his training in University Malaya and graduated in 1993 with MBS, and later pursued his studies in Master in Internal Medicine in University Malaya in 1996 to 2001, and further his studies in Infectious Disease Attachment in Royal Melbourne Hospital in Australia in 2003, and become Infectious Disease Specialist in few general hospital like Hospital Kuala Lumpur, Hospital Sungai Buloh, and also Johor Bahru. He also, as an adjunct lecturer of Faculty Medicine of Masa University for bedside teaching year 5 medical students and end of posting examination, and also adjunct facility member or lecturer of Faculty Medicine Perdana University. And he also a professional community as a life member of Malaysia Medical Association and a member of Malaysia Society of Infectious Disease and Chemotherapy. He also a clinical practice guideline coordinator for Hospital Sungai Buloh. Without further delay, I would like to present Dr. Lee Leong for his presentation. Thank you.
Mana satu gambar saya? Oh ya, buka. Mana yang satu yang ada virtual punya. Morning. Thank you everyone here to invite me to give a lecture on antibiotic stewardship and challenges. Actually, I should thank Dr. Sharifah. Every time Dr. Sharifah call me is actually challenging question that there is no right or wrong answer, and I always learning from Dr. Sharifah and Farah punya call actually. Rather than I'm giving them an answer, if Dr. Sharifah realized, in fact, he asked me to give a talk initially about COVID and quarantine period. I cakap, oh, Dr. Sharifah, saya susah nak kasih quarantine period ini. And rightly, today, our minister has changed the quarantine period, jadi shorten and shorten pula. So a lot of infection control, actually, there is no right or wrong answer. Infection control is very it's good to be head by a person who is very obsessive compulsive, but being obsessive compulsive probably not practical. Itulah every time Dr. Sharifah give me a call, my answer is about 15 minutes or half an hour long, and then we come up with a consensus. Yang tak ada salah dengan betul, kita kena practical. I selalu cakap dengan Dr. Sharifah, ini teori dia, tetapi ini practicality dia. Nanti jangan quote Dr. Leo kata macam ni. So don't get disappointed for any decision making in infection control, because if you feel that you are too confident, you are intelligent today, you look stupid tomorrow. You look stupid today, but you may be intelligent tomorrow. That's my motto to Dr. Sharifah. and talking about antibiotic stewardship, I actually start my infectious disease. I don't foresee infectious disease is so tough, because I joined infectious disease after Dr. Low will know. I joined infectious disease together with Prof. Adiba, because I do my master as a disease in infectious disease. So I tak sengaja terjerumus ke dalam infectious disease. Mula-mula I ingat senang nak buat infectious disease, sebab semua disease itu saya ada satu almari, tak payahlah saya pergi cari patient tau. Semua dalam almari itu confidential. Tapi I terjerumus 2 tahun I join infectious disease, terjadi SARS datang. So that's how I grow up together with infectious disease. So my knowledge is not only from textbook, more of melayang and belayar di dalam infectious disease and belajar dalam sana lah. So okay, talking about antibiotic stewardship is very challenging. I just go through this article, and then I just present what I finding in this article and tell you what are the challenges, and we will sail through, and don't be hesitant to continue discuss, and we are all learning together. So majority of clinician actually aware. I will say that kalau kata awareness on antibiotic stewardship, all of us are actually aware that antibiotic stewardship is important. Kalau kita tak gunakan antibiotik dengan berwaspada, satu hari nanti kita tak ada antibiotik. Saya umpama saya sekarang fikir balik, apa yang cikgu kita ajar kita masa zaman dulu itu kadang-kadang tak berapa betul ni. I think cikgu ajar kita, I ingat balik, makhluk yang paling bijak di dunia ini, kita sombong tau, kita ingat manusia adalah makhluk yang paling bijak dalam dunia ini. Betul kita sekarang tengok balik. Actually saya rasa bukan no. Saya nak cakap dengan cikgu ajaran sesat tu. Manusia bukan makhluk yang paling wibawa di dunia ini. Mungkin kita sekarang ada conference and meeting sekarang macam ini, makhluk satu lagi ada conference dia sendiri adalah kuman. Kuman dia tahu, oh Dr. Sharifah pakai augmentin. Next time dia akan resistant kepada augmentin. Kuman tahu kita pakai those yang buat HIV medicine. If you are not compliant with heart, dia akan jadi resistant. Termasuk influenza, dia jadi resistant kepada Tamiflu. So, kuman mungkin ada conference dia tersendiri untuk mengatasi kita punya antiviral, antibiotik, and antifungal. So, tetapi selama kita belajar di medical school, cikgu ajar kita mesti selamat. We need to be a safe doctor. We need to be safe doctor. The safe thing is to give broad spectrum antibiotic if you don't have a correct, if you don't know what is the diagnosis. And in one hand kita nak jadi safe doctor, kita dengan tidak sengaja, bukan kita sengaja. So I always tell my surgeon or whoever is, whatever we do, nobody is intelligent, nobody is right or wrong. You love your patient, you confident sangat, and you want to start broad antibiotic, tak payahlah refer Dr. Leong, you start saja. Semua kasih meropenem mesti selamat. Tetapi akhirnya kuman lagi bijak, dia jadi meropenem resistant. So saya mau cakap, kita sekarang macam asta juga lah. Kita kena ada strategi untuk berperang. Kita tak boleh simply lontar saja peluru. Nanti musuh kita tahu apa peluru, kita kalah juga. So kita kena pakai strategi. So So I would say that majority actually aware, but over 80% has responded, accepted, and need for direct feedback on their antibiotic selection. There are other banyak strategy in antibiotic stewardship. I don't have that slide here. There are the feedback, there are the pre-authorization, there are the macam kita guna prophylactic antibiotic, we don't prolong it. Kita ada stop order, kita ada prospective audit and feedback. Actually, I love the prospective audit and feedback, but the problem about prospective audit and feedback is very labor intensive. And you can see 83% of respondents agree that education, active participation from infection control, institutional guidelines, access to an institutional antimicrobial and prospective audit and feedback intervention would be most effective way to reduce antibiotic resistance. Yang cara kita kata stop order, pre-authorization, itu semua tak efektif sebab apa? Kita sibuk. Kalau katakanlah kita ada pre-authorization, ada surgeon, ada orang lain yang kata, oh, Dr. Sharifah saja boleh authorize. You ingat saya lagi bodoh lah. Saya mungkin lagi pandai Dr. Sharifah. So dia tak suka. And then dia rasa dia punya kuasa untuk order antibiotik sudah ada tekangan. So a lot of people don't like that pre-authorization. And actually pre-authorization for our pharmacy, I'm not sure who is the pharmacy here. Yeah, for pharmacy, you know how a consultant do pre-authorization, you go and audit. Because sometimes the consultant is busy, dia pre-authorization, dia punya diagnosis salah pun dia jadi betul kan. Kalau saya nak kasih meropenem, I tulis saja ESPL, dia pun tak tengok patient, dia tak tahu dia betul ke tipunya. So that is the pitfall about pre-authorization. The antibiotic stop order, another way of stop antibiotic stop order. The problem is stop order itu kadang-kadang patient not many people love it because sometimes patient come in ill and things happen middle of the night. The stop order already kata stop. Kalau kita tegas sangat dengan stop order itu, patient boleh meninggal. So stop order is actually good, but sometimes can be dangerous. So the stop order is not very favorable. Prospective audit and feedback is what I'm doing most of the time. As I become senior, I love because I'm being trained by Dr. Chris. I will say that he has trained me to discuss and communicate. We have to discuss and communicate. The win-win situation is we discuss and communicate. We can buy in from our counterpart because we respect. We also put ourselves in the shoes. We don't want you to use this antibiotic. We recommend you to use another antibiotic. What is your reason? And then our counterpart also can tell me what is their concern. At the end of the day, dia macam beli benda. Kita beli barang dekat pasar. Dia nak jual RM3. Saya kata RM2 boleh lah. At the end, kita deal dengan RM2.50 lah. So we come to a middle. So we can also minimize the non-judicious use of antibiotic. Instead of stop the antibiotic, let's say we come to a consensus, we use a narrower spectrum. So prospective feedback and audit is a better way. But kalau kita banyak sangat nak pakai meropenem, seluruh hospital Tengku Mizan, only satu orang sikin saja, dia kena tahu case itu. For prospective feedback and audit and feedback, you must know the case. If you don't know the case, our counterpart also, you cakap apa dengan saya, you tak tahu case ini, you main tempat cakap, oh tak payah. So for you, so that is very labor intensive. That's why to start off, maybe I suggest everybody should own antibiotic stewardship. We need to have a liaison officer in all departments, which I'm going to do now in Hospital Kuala Lumpur. Hopefully, the liaison officer should know the case and then we discuss. So that is a prospective audit and feedback. So majority of our professional interview voice concern about antibiotic misuse and overuse is widespread. So I think everybody aware of it. And physicians generally feel the problem was greater magnitude scope in community pharmacy than in private and in private hospital. But I will say this is not really true. Yeah, a lot of time private hospitals are more non-judicious because of medical legal, because of financial incentive also that make them a bit more non-judicious. But in our public hospital, there are also a lot of time we are in the reason non-judicious is not because of incentive on financial, but it's because we love our patient too much. I will always say loving too much is also spoiler. Okay. Most physicians confirm they routinely prescribe broad-spectrum antibiotic, felt that this practice was reasonable considering the severity of illness they treated. And from the patient record, the investigator determined that the door-to order time and into the emergency department to the order for antibiotic and the antimicrobial lead time from doctor order to the first time antibiotic being administered are very important. This is because of our sepsis campaign. Our sepsis campaign, this is where everyone, including this across the board of private and also public hospital, we always love our patient. Patient is not our enemies. We always want our patient to get better, and we feel satisfied if our patient getting better. So dia macam the sepsis campaign ini sudah buatkan macam acute myocardial infarct. If a patient come with ST elevation, door to streptokinase or RTPA is very important because you salvage the myocardium. So the later you start the later you initiate antibiotic, the chance of patient go into septic shock will be higher and mortality will be higher. So I do agree that initiation of antibiotic cannot be delayed if the patient is in severe sepsis. But one thing people always forgot is you go and audit emergency department in hospital under the blood culture portal, and are we doing blood culture before we start antibiotic? This is always forgotten. So we need to also audit all the patients being started antibiotic in emergency department mesti buat culture. Jangan-jangan you tak buat culture, lepas itu patient not responding to antibiotic, refer ID physician. ID physician, I always tell Sharifah, we are not the intelligent species in the world. At the end of the day, if you don't have a culture, we are also main tembak juga. Tak tahu lah tembak itu betul ke tidak. So source of sepsis should be removed. One is a blood culture or any culture should be given before initiation of antibiotic. It's not wrong to start antibiotic early, but must remember to do blood culture. And if the patient has any source of sepsis, we just discussed just now over our discussion. If the patient has source of sepsis, referral to surgical department is utmost important because we need to remove the source of sepsis rather than just tembak antibiotic. And initiation of antibiotic is the time to the door to antibiotic time is important only in patient who has full sepsis. Janganlah you anggap semua patient masuk dengan demam pun you kasih antibiotik cepat-cepat. This include example will be endocarditis. If you suspect endocarditis in the patient is stable, you can always wait and do the 3 set of blood culture first. So some patients do not have that kind of hurry, but the kind of hurry is in patient in full sepsis. Give you another example. This is a case scenario. I love to give case scenario so that we can learn from the case scenario. A patient blood culture, they're admitted, I can't remember. Yeah, I think these are the common things that we see in post-COVID era. In post-COVID, patient come in COVID, as Dr. Sharifah said, you all will present a case later, and along the line, patient develop sepsis, and you do a blood culture, patient got Klebsiella pneumonia, and this Klebsiella pneumonia is not resistant, it's very friendly, it's sensitive to augmentin, unicin, substriazone, semua sensitive. You see the antibiogram, semua sensitive. But CT scan show necrotizing pneumonia with right lung empyema. Malangnya, now we got invasive Klebsiella syndrome. Invasive Klebsiella syndrome, this Klebsiella is very virulent. It also causes prostatic abscess And then from prostatic abscess, it extends into the perirectal region and pelvic loculation. Also, it can also invade the eye and cause endophthalmitis. So this kind of patient has very poor outcome. So if you know that this is the organism, you know this is the sensitivity. The common antibiotic, I think everyone to use will be either you use Unacin also okay, ceftazidime also okay, ceftriaxone also okay. After 1 or 2 weeks of this antibiotic is not working, what is our spinal reflex? Really? You will go to meropenem lah. That's majority our spinal reflex. So I don't know why majority of clinicians now thinking if the patient not improving, maybe ini antibiotik tak cukup kuat. Kita kena guna peluru yang lebih hebat. So pakailah meropenem. Tetapi this patient got so much of abscess. You nak refer siapa dulu? Nak refer cardiothoracic. Banyak kalau nak refer surgeon ini, urology pun kena refer. Lung pun kena refer, siapa kena masuk dulu? You potong atas bawah tak potong, tak jadi. Potong bawah atas tak potong, tak jadi juga. So I will say that this kind of case, actually if we don't know, these are the complicated case we see day in day out now. I will say that communication between doctors is quite important, and we are lacking this kind of communication nowadays. If you don't know who to refer, kadang-kadang refer banyak sangat, orang kata kita gila refer semua. Tapi the fact is kita perlu refer. So, and kita tak boleh refer satu-satu, you pun penat. Cakap dengan, you sudah hafal cakap dengan cardiothoracic surgeon, you punya masalah, ulang lagi dengan urologist. Urologist suruh you thoracic surgeon masuk dulu, sebab atas belum buat, bawah tak boleh buat. And then cardiothoracic you call urologist dulu, buat prostate dulu, baru saya buat itu. Akhir patient mati lah. So this kind of case, we need to have an early multidisciplinary discussion. Now got virtual, I think my voice is also being recorded virtual, betul tak? So when you do virtual, we can discuss among all the discipline, and when you go in, we go in one shot. And if need to minimize and stabilize the patient, and we need to discuss a consensus when is the good optimal time stabilization that you want to go in. If you sometimes we just discuss, our NS will prefer the patient to be stabilized first, but sometimes the source is not being removed. How to stabilize? The patient will be forever hypotensive. You nak stabilize sampai PP naik, you kasih inotropic sampai patient punya tangan pun sudah blue, vasoconstriction is also not stabilized. So all this have to be early discussion. So antibiotic stewardship is not to just escalating antibiotic, but also discuss the source have to remove before. Sometimes the patient is not improving, is not because the peluru tak cukup kuat, is because you tak pakai parang, kena pakai parang pula, bukan sahaja, bukan ada peluru, kena kadang-kadang kita ada senapang lupa parang pula tu. Parang keris pun mungkin berguna juga. So this is strategy, source control. So this is where and source control is very important to also explain to a relative, because kalau you cakap dengan patient potong sini, potong sana, senang aja cakap potong sini, potong sana, layman will not faham. Layman will say, you potong macam ini, mana lagi saya tinggal? So this is anonyms that I will say. But when you have cancer, orang takut. Bila ada cancer, orang kata radical resection. Sebiji cancer sel pun tak boleh tinggal sana, kalau tidak dia akan metastasis. Tetapi bila ada antibiotik, semua nampak Dr. Leong. Dr. Leong bagus tau. Dr. Leong pandai. Dia boleh kasih antibiotik, semua kuman bunuh. Wah, kalau surgeon lagi puji saya lagi takut. Actually, I will tell the patient, saya bukan pandai sangat juga. Saya punya peluru mungkin tak boleh masuk you punya abscess wall. So radical debridement should not be limited by the concern of creating bone or soft tissue defect. Sometimes I pernah bincang dengan orthopedic surgeon. Dia cakap dengan saya, Dr. Leong suruh saya debride the spine. Dr. Leong kena faham, twin tower kalau backbone sudah debride, twin tower runtuh. So this is where we have to discuss and communicate whether the best is has total debridement and radical resection, but when time comes that is impossible, then we may need to go down to long-term suppressive therapy. Macam Dr. Low tadi cakap dengan saya, the mucormycosis go to the brain already. Berapa lama kita nak kasih amphotericin B seumur hidup? Unless you potong the otak lah. Potong otak macam mana nak hidup? So that's why early debridement and early surgical intervention sometimes is important. Rather than you give early antibiotic, you have to tell our colleagues early antibiotic is important, but too broad antibiotic at the beginning is also not good. If I say that example is the Klebsiella syndrome, because if you give broad spectrum too early, you down with no antibiotic very fast. You become CRE. So these are the game that we play when we do antibiotic stewardship. Okay. When we do the survey in Africa, that during this survey, they also admitted to frequent switching, combination, and using broad spectrum antibiotic for surgical prophylaxis and continuing this post-operatively to prevent surgical site infection. So this is another method that pharmacy can actually audit. A lot of time we give antibiotic, surgical discipline probably sometimes worried about infection. They tend to prolong the antibiotic. A good example I can give is I'm not saying that all surgeons will behave like that. Don't quote me. Sometimes we love our patient. We have imagine a patient who, I give you another example. Patient has infective endocarditis, and surgeon need to replace the mitral valve or aortic valve. And after you replace the mitral valve and aortic valve, it's the metallic valve, especially after that you need to put the patient on warfarin. And after you put the patient on warfarin, unluckily, patient can be over warfarinization, and patient can become hemorrhage into the lung. And the patient hemorrhage into the lung, NS will say, kenapa dia punya ventilator setting keep on tinggi? And then you buat a chest X-ray, X-ray ini macam pneumonia. Dan kasih Unisin tak jalan, kasih meropenem. Tetapi apa yang kalau you buat CRP dengan procalcitonin 0.1. But X-ray macam itu, siapa berani tak mau kasih antibiotik? This patient already on prophylactic antibiotic cefazolin sebelum operation. Biarlah saya continue lah. And continue forever lah. Sebab X-ray forever macam itu. Tetapi the fact is, the patient is actually having pulmonary hemorrhage secondary to over warfarinization. So these are the things that kita kena give and take and see when is the suitable time we have to discontinue the antibiotic sebelum jadi CRE. So the prophylactics kadang-kadang prolong because patients are not doing well. Okay. Most physicians admitted they were rarely guided by microbiology result, and that patient remained on antibiotic for long duration with antibiotic cessation simply coinciding with discharge of patient from hospital, especially CAP without positive culture. So this is another thing that kita boleh audit. We shouldn't give antibiotics sampai patient discharge. Perception on optimal approach to implementing AMS. both restriction and audit were quality improvement tool, and it's better to adopt a mix of intervention. Auditing is very good intervention, but very resource intensive, and it might be difficult to apply to all wards. So sometimes you want to choose certain ward so that you are able to cope rather than you get tired. Kalau you nak buat audit seluruh hospital, you get tired after that. So you choose a ward that is high usage of antibiotic. Okay. Okay. Pharmacy were the more likely to identify inappropriate combination, doses, or pharmacokinetic or pharmacodynamic parameter than physician, but tended not to communicate with their observation to prescribing physician for the simple reason that this professional group hardly ever interact. Sebab kadang-kadang pharmacy kena you all has an inferior feeling. You tak boleh ajar doktor. Actually, that is not correct because nowadays, if you are a Dr. Shanhani belum ada sini ada. Like we just discussed, if pharmacy which PhD and all that, they are very good in pharmacodynamic and pharmacokinetic. Giving meropenem is not superior to giving tazocine for prolonged infusion mungkin. You can actually prolong the infusion instead of giving infusion 1 hour, you prolong the infusion to 3 hours. I always talk to my pharmacy because I don't know how stability of the drug. Sebab pharmacy yang paling pandai stability of the drug. Selamat pagi Dr. Shanhani, baru I cakap stability of the drug, dia sudah masuk ni. Bagus. So I will ask our pharmacy, Dr. Shanhani, Augmentin boleh infuse berapa lama? Tazocine boleh infuse berapa lama? Meropenem boleh infuse berapa lama? We give infusion prolonged infusion for beta-lactam antibiotic because the killing effect is time above MIC. So if your patient is not responding, you can actually prolong the infusion by using a narrower spectrum antibiotic. That is another stewardship program. So core elements for antibiotic stewardship, kita kena ada leadership commitment, accountability, drug expertise. We need to action to implement, tracking, reporting, and then feedback lah. So that's why leadership is important. Datuk pengarah kena support kita, kena kasih resources, so that it's better to have a computer system so that we can track back. Sebab kalau tak ada computer system sekarang, semua saya Dr. Shanhani in HKL, saya punya 72-hour feedback form semua tak sampai kepada pharmacy. Pharmacy blame the nurse tak hantar. Nurse kata sudah hantar, pharmacy sudah telan. Saya tak tahu siapa betul, siapa salah. So we need to have that kind of tracking system so that we can audit back whether the 72-hour reply form itu ada ke tidak. So clinician need to be fully engaged because we need to buy in surgeon, buy in the orthopedic, semua, including intensivists, because source control, all that are more important than just using antibiotic alone. We need to use that as a quality improvement. And lab is very important also for antibiotic stewardship. Rapid tests, because a lot of community acquired pneumonia are being given antibiotics sebab orang ingat semua community acquired pneumonia ini bacterial origin. Tetapi bukan semua community acquired pneumonia are bacterial origin. Sebelum COVID, half of them may be influenza. Sekarang you tengok banyak adalah coronavirus. I will tell you coronavirus, should we give antibiotic to prevent superimposed bacterial infection or not? For all our patients CAB, actually there is no data on that. So I will say that we have to yang ini I sudah go through. I just want to tell you the go back here. Yeah, I have this data is very important, but we don't show this data anymore because we hardly have time for audit. This is the Prof. Liang punya data. He published in his I find this in one of the article that we used to give augmentin azithromycin as a spinal reflex. Semua patient CAP augmentin azithromycin, augmentin azithromycin. Is azithromycin really indicated in all patients CAP? Nanti Dr. Shan Hanim, all the pharmacy will goyang kepala. Semua kita spinal reflex kasih semua. But go back to this data and see, actually mycoplasma pneumonia ada. Dia bukan tak common, tapi dia bukan common sangat juga. So this is where I said a laboratory investigation is very important. But kita punya mycoplasma, how we detect mycoplasma pneumonia in our setting? Kita hantar serology. Serology is not very good. Serology can be past infection. We need a PCR testing untuk mycoplasma, tetapi mahal. So we have to acknowledge that these are resources that mungkin kita kena invest for antibiotic stewardship. And this is another data, sorry, a bit blur, that I truly from Singapore punya study. They found that commonest cause in one of the Singapore hospital, masa influenza sebelum coronavirus lah. The commonest, this is done in before the coronavirus era, the commonest cause is actually influenza. I still continue to survey influenza. Sekarang coronavirus will take over influenza, but all these patients may not require antibiotic. Yeah, so this is a thing that I explained. Why not we use beta-lactam monotherapy in community acquired pneumonia unless the patient has a confirmed mycoplasma? And this is a study in one of the international conference. They put down there 75% of our patients come with COVID-19 are actually being prescribed antibiotic. Tetapi if you see we always worry about bacteria superimposed infection. The bacteria superimposed infection only 8.6%. Dia lebih rendah daripada bacteria superimposed infection secondary to influenza virus infection. So the bacteria superimposed infection doesn't say it's none, but it's very low. So we need to be use antibiotic cautiously in our COVID-19 patient. Yeah. Okay, so we need to have a CME, continue to educate, continue to buy in. So be antibiotic aware, use it smartly and carefully. Otherwise, we will run out of antibiotic. Thank you. I think, is it okay? Yeah. Soalan ke nak dengar Dr. Shan Hanim dulu? Huh? After the presentation.
Thank you, Dr. Leong and Children, for your informative session. Next, I would like to invite our esteemed speaker, Dr. Shahanim binti Adnan, Head of Pharmaceutical Services, Sungai Buloh Hospital, to deliver her talk, Point Prevalence Survey. I would like to take this opportunity to introduce a few details about our speaker. Her name is Dr. Shahanim Adnan. Among the first pharmacy in Ministry of Health who has pursued research of higher degree in field related to infectious disease. She obtained her PhD in 2014 from the University of Queensland, Australia, in area related to PK or PD of antimicrobial in critically ill patients. Graduated from USM Penang in 1996 and did her master in clinical pharmacy at UKM in 2003 to 2004. She did her training in Hospital Seremban before she was posted to District Hospital Tanjung Karang in 1997. Obtained her master in clinical pharmacy before she joined Hospital Singapura as one of the core team in 2006. And since 2016 until 2020, she was appointed as the chairperson for National Antibiotic Committee under Pharmacy Division in Ministry of Health, team member of National Committee of HIACC and Technical Working Group 2 AMR Surveillance and Research under National Antimicrobial Resistance Committee. She is still in the editorial board of National Antibiotic Guideline. She also a writer for chapter of cephalosporin surfactant for creatures the use of antibiotics, editorial board for National Antibiotic Guideline, first, second, and third edition, Ministry of Health Malaysia, advisor of Antimicrobial Stewardship Focus Group, Malaysian Pharmaceutical Society of Malaysia. To the date, she has multiple publication like pharmacokinetic of beta-lactam antibiotics in patients with intra-abdominal disease. So without further ado, we would like to present Dr. Shahanin to present his presentation. Thank you.
Okay, saya dulu ni. Saya ni rendah tak pakai rasa. Sorry ya. Actually ni nak masuk ni. So, Assalamualaikum warahmatullahi wabarakatuh. Thank you for the kind introduction. Pengarah, sorry, I don't get your name and to and the siapa untuk dibalik tak sih. Okay, first time saya datang sini sesak sebenarnya. Tapi saya nak cakap saya terlibat dengan EPM masa GKB Task Force. So masa tu saya cakap dengan dia tu nak mana hari saya rasa macam nak join EPM pula. Sebab masa experience dengan GKB tu macam tak tahu cakap lah, perasaan tu macam saya sangat senang kesempatan nak ucapkan banyak terima kasih pada ATM bantu kami, especially masa oksigen kami tengah oksigen kita tak ada masa nak angkat tong-tong yang besar tu. Bila ATM datang dengan body kita dekat mortuary dah pile up sampai tak ada tempat nak letak sampai kita punya mayat rosak kan. Routine mayat dah macam rosak semua. Masa peak tu saya rasa macam Allah hantar tentera dari langit turun. Sebab itu masa tu zaman malam raya haji saya tengah buat rendah, saya buat Excel projection ubat baricitinib prosedur semua untuk claim value. Call HKL, call sembang malam raya haji. Sebab malam tu juga dia submit dekat GKB Task Force nak dapat program. So masa tu tengah peak teruk sangat. Betul dia pun buka dekat parking kan. Sempat dah nampak parking dia. Sorry lah, masa COVID kita macam emotional sikit. Dah 2 tahun siapa. Okay. So back to BPS. Alright. What I'm going to do, is it okay cakap dalam bahasa Malaysia? Okay, wait lah. Alright, never mind. So, if talking about stewardship, pharmacy driven banyak sebenarnya. So, I think Dr. Long dah sentuh tadi, pharmacy punya contribution or role dalam AMS banyak. Tapi saya diminta cerita pasal PPS dulu. Sebab saya rasa ini macam basic thing yang agak mudah, doable. Tapi walau macam tu dia kena training lah dan because actually the best trainer for this is ID physician dan saya dapat personal training lah masa tak adalah nak kata official sangat tapi sebab saya kat Sungai Buloh. So kalau tak ada in contact with ID may be difficult you nak interpret data, nak collect data. But this PPS dia bagi insight what's going on in terms of prescribing practice of antibiotic, and it's a good feedback to the doctors, to the clinician, to the pengarah, and to your management level Dan from there actually you can do some intervention. So I will share PPS yang MOH buat 2018, dan intervention kita adalah kita modify energy. Saya tak tahu whether you all aware, energy guideline was launched in 2019, just before COVID. Dan sebelum kita buat energy tu, kita buat PPS. Masa kita buat PPS, kita kumpul banyak issues. Kita collect issues dan editorial board saya dalam tu. I think Dr. Gafur involved dalam energy. Kita dapat input daripada clinician kenapa dia tak ikut guideline. Dan sebenarnya guideline dia bermasalah yang perlu diintervensi, bukan prescriber. Ada certain prescriber yang salah lah. Tapi ada certain guideline tu yang kena diimprovise. So kita nak buat PPS lagi sekali insyaAllah tahun ni, bulan 12. Nak tengok ada kesan tak bila energy tu kita tak improvise. Masalahnya orang energy ni tak ada apps. Dia boleh download kat PDF sahaja. So mungkin orang tak aware pun energy. Itu kita punya cabaran lah. Okay, so PPS ni sebenarnya WHO dah lama buat. Dan kenapa buat PPS? Saya tak aware, tak sure, bagi seorang aware tak, kita dah lama monitor antibiotic usage. Dan hospital tempatan tertentu pun ada bagi data tu dekat KKM. Dan actually MIDEF punya penggunaan ubat agak tinggi lah. Antara yang tinggi untuk certain antibiotic. Okay, tapi tak cukup. Kalau kita monitor usage saja, dia tak mampu menunjukkan apa masalah yang berlaku on the ground. Dia just tunjuk usage saja. Dan kalau you ada outbreak, contoh you ada CRE outbreak kan, doktor yang confirm lah pakai kolesterol tinggi kan. Jadi you tak boleh query kolesterol dia tinggi. It's appropriate sebab memang ada outbreak. Kalau you ada outbreak MIC, vancomycin you akan tinggi. So usage tu tak menggambarkan the real picture. Okay. Tapi PPS dia lebih in depth. Dan dia buat satu hari je. Dia macam kita ambil gambar snapshot what happened on that day. Okay. Dan PPS ni selalu infection control buat. Saya tak tahu infection control buat HCI, hospital acquired. Baru nak start. Okay. Okay. Infection control kita dah lama buat compare dengan antibiotik. Diorang dah buat 10 tahun macam tu. Berapa ramai patient dapat HCI. Itu yang saya curious sebab bila laporan HCI keluar, katakan yang semua hospitalized on that day, kadang-kadang infection control bagi report 10% atau 0.1% je patient ada HCI. Kan Dr. Long, sikit sangat. Tapi antibiotic usage 70%. So 70% pakai untuk apa? Takkan semua untuk community. Jadi that's why 2018 saya tak ingat, saya brainstorm, saya cakap dengan saya propose kat komiti nasional kita combine HCI dengan antibiotik buat sekali. Jadi kita boleh tallykan data tu macam dan MOH masa start 2018 kita turun padang, infection control turun, antibiotik pharmacist turun, kita tengok sama-sama patient. Okey, dan itu perubahan yang kita buatlah 2018. Kenapa PPS? Macam saya cakap tadi lah, antibiotic usage kalau kita monitor macam Sungai Buloh dah lama kan, daripada 2006 kita dah pantau lah, lama dia jadi plateau tau. Usage tu tinggi forever macam tu, dia tak turun tak naik. Lama-lama usage data tu tak ada meaning sangat. That's why dan apa yang kita propose adalah bila usage you gone up, carbapenem naik dekat ICU controlnya, buat PPS kat ICU untuk carbapenem. So you boleh tengok carbapenem tu pakai untuk apa. Lepas dah tahu dia punya isu dan boleh buat intervention. Kita buat QA project lah kalau perlu. Itu kena bincang dekat level hospital tu. Okay. So saya nak tunjuk data ni, baru je present bulan lepas. Meeting dengan DJ lah. Nampak turun sikit dia, color lain-lain tu lain-lain antibiotik lah. Kalau kita protokol MS launch tahun 2014 dan kita nampak ada kesan turun sikit kan kat 2017 ni, tapi lepas tu naik balik. Dan sebenarnya saya expect lagi tinggi 2021. Sebab tak habis lagi tahun ni, tak boleh nak tunjuk lah. Kalau usage dekat Sungai Buloh memang sikit bersama kan sebab COVID kan naik banyak kan. Sirot masalah. Cerita lain sirot. Okay. Alright. So 2021 memang kita expect tinggi. Memang kita punya infection control pun kata masa COVID mula-mula menyerang tahun lepas, tak ada nampak sangat haiwan-haiwan muncul tau, haiwan-haiwan. Doktor dia pakai, dia cakap hospital saya macam zoo, ada banyak haiwan. Haiwan tu mikro tu lah memang CCI semua tu. Tahun lepas tak banyak sangat. Tahun ni tak tahu, COVID dia lain macam sikit. Memang keluar semua order MDR. Tak tahu lah dekat hospital tourism macam mana. Bukan nak Mindef warna pink. Saya silap. Sorry tapi confirm warna pink lah. Bukan nak ni sebab kat sini semua orang Mindef kan. Alright. So nampak tak your carbapenem kat ICU a bit on the high side. Warna hijau tu MOE tak silap. Okay. Dan tapi carbapenem ni bukan ubat yang mudah untuk diintervensi. Macam Dr. Leon dia cakap 72 hours ada untuk carbapenem kan. Orang tak isi orang pun kan. Tapi ubat dapat. So, memang carbapenem susah. 90 tu struggle nak control usage. Okey, ini adalah definisi PPS. PPS adalah satu hari kita pergi audit ward, semua ward kita pergi. Semua patient yang on antibiotic kita masuk dalam data kita. Dan kalau yang infection control dia tengok semua patient yang HAI. Tapi indikator dia adalah antibiotik. Siapa patient on antibiotik, infection control team akan probe further whether dia ada HAI ke tidak. HAI susah sebab dia ada definisi WHO yang sangat strict. Dia fulfill semua kriteria tu. Doktor mungkin kata dia pneumonia dan dia on antibiotik. Tapi CDC punya guideline sangat strict. Dia tak fulfill kriteria tu, infection control tak boleh cakap di hospital for pneumonia. Jadi that's why HAI yang captured by infection control dia akan rendah daripada apa yang doktor diagnose. Sebab doktor diagnose ikut dia punya kriteria dia sendiri. WHO ada kriteria, CDC ada kriteria. Infection control terpaksa ikut kriteria tu. Dan semua patient antibiotik kita, pharmacy akan audit tengok compliance guideline. Okay. Dan ini yang kita dah buat lah 2018, so saya nak share apa yang kita dah buat. Sebelum kita buat PPS tu, kita run pilot project dulu kat Sungai Buloh. Dr. Ben marah lah letak gambar ni sebab nampak kepala. Tu Dr. Ben, Dr. Sureh, Dr. Afah, ID team sebelah situ, sebelah sana tu my team lah pharmacist. Saya ada full time pharmacist MS. Buat MS saja. Jangan jealous Okay. Dan sekarang saya letak 3 orang. Dia buat MS saja. Tapi masa COVID, dia buat kerja COVID lah. Yang ni saya tak expect lah hospital lain mampu buat sebab dia ikut pada manpower. Dan ni saya nak just give credit to them, orang yang buat manual PPS. Dan kita buat training dan kita promise. Ini form dia. So basically memang tak nampak lah. Basically senang je nak faham. First, pharmacist kena tengok indication apa untuk antibiotik. Indication bukan diagnosis Patient mungkin datang untuk COVID, tapi bila doktor start meropenem bukan untuk COVID lah kan. COVID antivirus. Right, so kita kena tanya meropenem tu untuk apa? Sepsis, sepsis sebenarnya tak ada dalam guideline pun. nak audit susah. So yang itu yang susah sikit. Sebab once kita dah tahu indication dia apa, tak tahu siapa kat sini biasa dengan NHG. NHG dia punya infection dah ikut organ system respi, GI, CNS semua. So cari kat situ, tengok compare tu guideline ke tidak. Dan yang isunya adalah kalau dia adalah definitif. Definitif maksudnya CNS dah balik. Kalau CNS dah balik tak boleh ikut guideline dah. Sebab guideline ni sepatutnya untuk guide clinician masih empiric tu, belum tahu infection tu apa. Atau belum confirm lagi, dia just suspect saja. Okay. Yang definitif tu saya tak advise pharmacist probe further untuk audit. Tapi kalau you ada clinician to guide you, clinical pharmacologist atau ID physician, dia akan assess whether definitively antibiotic choice dia okay tidak, ikut culture ke tidak, spektrum tu narrow to broad. Itu perlukan training lah. Yeah. Okay. So this is the algorithm. Basically, I go fast. Dan Sungai Buloh sahaja masa buat PPS 2018 kita buat appropriateness. Kita bukan hanya tengok compliance saja. Appropriateness ni kena input daripada clinician. Pharmacist tak valid, tak credential untuk buat appropriateness. So appropriateness kena ada microbiologist dan kena ada physician. Infection controllers pun ikut sekali sebab dia nak tengok infection tu apa. Alright, so this our energy dia ikut sistem lah. Okay, saya just nak show finding. So ada dua result, satu prevalence, satu compliance. So our MOH data show 40% patient on antibiotic. Maksudnya daripada 10 patient yang admitted dekat hospital, 4 pesakit dapat antibiotik, which is high in my opinion lah. 40% is quite high, tapi bila kita compare dengan national data, lebih kurang macam ni juga. Tapi kalau you tengok ICU yang hujung sekali, 80% tau, 70%. Maksudnya 10 patient kat ICU, 8 patient on antibiotic. That's common, right? That's second. So ICU yang actually kita perlukan perhatian lebih ni, sebab kat ICU ni kalau jadi outbreak memang teruk. Dan kita tahu kalau you pakai banyak Genchem, nanti SPL banyak. Kalau you SPL banyak, you akan pakai carbapenem banyak. You pakai carbapenem banyak, keluar air ma'ruf, MDR semua. Okay. So have to pay attention to ICU in any hospital. Kalau nak buat intervention tu saya just, tapi ICU bukan senang nak buat intervention, the most difficult. And surgical based discipline pun higher prevalence of antibiotic. Average 40% kan. Tapi surgical based discipline memang pakai antibiotic sampai 80 to 60%. Dan ini feedback kita bagi pada HOD. So pharmacist punya role adalah bagi feedback sahaja. Bukan propose intervention. Kami punya role bagi feedback pada clinician, bagi feedback pada HICC, bagi feedback pada pengarah. This is how antibiotic is used. Whether it's appropriate, whether you need attention, the whole team have to listen to that. Dan empiric memang tinggi. Daripada 10 antibiotic yang doktor prescribe, 7 adalah empiric. Culture result tak balik. Kadang-kadang culture result balik pun sambung je lah lagi 3 hari, nak completekan 7 hari. Tak step down pun tak apa-apa. Kan Dr. Leong. 3 hari saja. Ni dah 4 hari dah. Lepas tu kadang result pun balik, tambah. Ada mantuk kat sini. Kan nanti kena so masa kita nak buat 72 hours to order kat Sungai Buloh dulu, memang kita cakap dengan mantuk, kalau you tak boleh produce CNS dalam masa 72 jam, pharmacist tak boleh implement 72 hours to order. Doktor akan cakap result tak balik lagi. Dan dia akan continue. Itu tak betul. So kita punya mantuk kat sana, dia keluar terminal result dan at least ada gram cell, gram naik, gram pause. Itu guide doctors, at least something. And then kita mampu microbe untuk produce result cepat. Kalau tak, kita tak boleh nak buat policy 72 hours order. We have to be fair with our clinician. Kata result tak balik. Tapi kalau diorang silap macam diorang punya on their end yang tak hantar culture, then that's another issue lah. Okay. And carbapenem the most empiric antibiotic. Masuk serangga. Okay. So bila kita tengok carbapenem memang majority prescribe empirically. Result tak ada. Dan supposedly carbapenem ni bila result dah balik you kena step down. Bila supposedly kita kena reserve untuk ESPL dan yang susceptible. Kalau ikut microbe memang carbapenem susceptible pada semua pathogen. Dia akan bunuh semua. Dia macam machine gun. Tentang kat tentu dia bukan sharpshooter. Okay. Dia akan kill all your bug. And once they kill all your bug, keluarlah all this selective resistant. Microbe boleh cerita pasal tu. Dia bunuh semua. Nanti yang hidup tu yang resistant. Keluarlah MDR, Resimeto, keluarlah CRE. Once you pakai banyak carbapenem, kolesterol akan naik. Cuba tengok, setiap kali kolesterol you naik, carbapenem you tinggi ke tidak? Dan ada besar kemungkinan sebab you pakai carbapenem banyak dan dia induce your MDR pathogen that you have to use kolesterol. Masalahnya sekarang ni, kolesterol dah mula resistant. Dalam IDSA guideline, kolesterol already removed from the guideline for CRE because it's no longer working. That if you lose your kolesterol, we are dead. Ada antibiotik dah habis. So before we came to that situation, we have to preserve whatever antibiotic we have right now. Ceftriaxone ni pun salah satu antibiotik yang sangat famous, especially ceftriaxone. Every single thing boleh pakai ceftriaxone kan? CAP boleh, apa lagi? Meningitis boleh. Semua boleh kan? Itulah isunya. Sepatutnya boleh step down ke maintain, step down pada antibiotik lain. Tak semuanya kita kena pakai ceftriaxone. Leptospirosis, kalau suspect tak tahu apa nak bagi, memang doktor bagi ceftriaxone lah. That is common. Actually, it's not about the initiation. Yang penting review tu lepas NSA balik. Dan kita punya guideline not too bad lah. 20% tak comply to guideline. Tapi bila saya zoom down, kita nampak interesting results. Kita perasan from our data, surgical prophylaxis diorang tak follow. Dalam guideline dah cakap surgical prophylaxis. For example, if I know second ONG dia pakai lain, dia tak ikut guideline. Lepas tu kita counter balik dengan diorang masa buat NAG 2019, betulkan balik ikut apa yang dia nak. Sebab kadang-kadang dia jadi isu macam ni tau. Doktor akan cakap, you audit I ikut guideline apa? Oh, I tak pakai guideline tu, I pakai guideline lain. Dah sudah. So sebelum buat apa-apa audit ni, HICC kena approve dulu guideline mana yang clinician kena ikut. Memang kita propose NAG. Tapi NAG ni kena custom made ikut hospital tu. Dan Sungai Buloh kita dah adopt NAG, kita keluar hospital Sungai Buloh guideline. Dengan konsensus daripada semua HOD. Dan masa kita buat HAG tu, kita dapatkan komitmen dari semua pakar. Pakar komit, dia kalau you nak ikut NAG ke tidak? Okay, I tak nak ikut, I nak guideline I. Okay, you letak guideline you. Nanti kita endorse. Dan bila kita audit, dia tak boleh cakap, dia tak boleh tuduh kita balik lah. Sebab I audit ikut guideline yang you sendiri dah endorse. So you tak boleh cakap I tak ikut guideline sebab you pakai guideline lain. Yang tu kena settle dulu sebelum buat audit. Kita tak nak dindong-dindong kat situ dah result audit dia dipertikaikan. Okay, sangat penting untuk settlekan isu guideline dulu sebelum buat audit PPS. Okay. Otherwise kalau semua orang setuju pakai NAG, dan NAG lah. Okay. Ini yang kita perasan dengan sejenak dia punya surgical prophylaxis tu dia pakai lain. Tapi ni saya cakap sebelum NAG keluar. Lepas tu kita dah revive lagi. Respiratory infection pun isu dia azithrol tu lah. Semua combine. Dalam guideline tak semua perlu combine. Itu clinician kena cerita. Bila nak combine, bila tak combine. Okay. Right. ONG yang paling tak ikut guideline. Antibiotic choice dia lain. Tapi ni bukan cerita pasal appropriateness cerita pasal comply to guideline sahaja. Orthopedic 20% not too bad lah. Yang tinggi ONG. Dan surgical infection, auto memang dia dah komen, saya tak komen. Okay, so auto memang tak ikut guideline langsung. Dia punya guideline sendiri. Allah Alam. Memang tinggi lah. Memang sampai masa present kan nampak kan obvious kan macam tinggi. Dia seorang je tinggi kat sebenarnya cuma rendah. Ni surgical infection bukan surgical prophylaxis. Kita tahu common infection dekat auto apa. Alright, so tapi ada isu guideline yang NPC untuk select. So kita dah bagi feedback pada auto, dia nak tengok balik, lepas tu kita revise balik guideline auto dan hopefully kita buat PPS sekali lagi, they will improve on this lah. Dan saya akan cerita kenapa compliance ni penting, dah ada connection dengan appropriateness, nanti saya tunjuk datang. Dan respiratory infection lah macam saya cakap tadi, semua combine azithrol. Alright, okay. So most of the issue is antibiotic choice lah. Dan not indicated. Not indicated ni saya pun hati-hati sikit, saya tak pasti macam mana dia interpret not indicated tu. Memang kita kena portfolio, mungkin clinician akan argue kenapa you boleh come to that conclusion not indicated. Ya. Ini kadang-kadang sebab kita tak jumpa dalam tu dia punya indication. I don't know, I need to put that 21%. Okay. Alright, so I want to highlight on this. So macam saya cakap tadi, Sungai Buloh buat appropriateness study. Appropriateness study maksudnya semua patient kita audit untuk compliant, kita sit down dengan masa tu Dr. Yasmin, our ID consultant, our clinical microbiologist Dr. Tuan Suhaila, our infection control team, kita duduk kat lab, tak ada duduk kat lab. Dia akan tunjuk tengok CNS result semua patient dan Dr. Yasmin akan review dan buat dia punya test appropriate or not. Okay, clinical punya review lah. Dan saya bahagikan result ni ikut the compliance atau the definitive atau the non-compliance. Ni not accessible, tak dapat nak prove for the case ni. Kalau you tengok yang kategori comply tu, majority are appropriate. Okay, tapi yang tak comply 50-50. You tak boleh cakap dia tak comply pada guideline, dia tak appropriate tau. Sometimes dia tak comply tapi appropriate. Macam kita ada isu dengan guideline cellulitis, jadi kita nak promote pada clinician adalah you follow guideline, you will be appropriate more or less for empiric. Kalau result dah balik, dia ikut result. Okay, tapi sebab Sungai Buloh je buat. So lain semua tak mampu buat appropriate because dia memang perlukan komitmen daripada clinician. Pharmacist tak boleh buat. So this is the something I don't have to explain. So what we do is that kita launch NAG 2019. Ni gambar YB lama lah. Okay. Lepas tu kita nak expect semua orang adopt NAG, lepas tu kita tengok yang mana high usage antibiotic, kita buat PPS. That's what we propose. And yang high usage antibiotic tu kita buat intervention lah, lepas tu buat PPS. So ada juga kita notice clinician complain, indication tu tak ada dalam guideline. So kita improvise our guideline. Dan ada practice tak sama dengan guideline, kita ubah juga. So saya nak credit to my pharmacist yang buat PPS dalam 2018. This is the whole team of MOH. Okay, dan saya nak juga promote kat sini. Bulan 11 kita akan buat training untuk PPS. So kalau hospital tu berminat nak join, saya suggest you approach our MOH for Nazima. Saya bagi nombor dekat email address dekat meja kan. Selalu panggil dekat meja Liza. Dan kita akan buat PPS 1 hingga 14 Disember. Ini MOH saja. Kalau Dr. Liza nak join, kena approach MOH lah. Training kita akan buat untuk pharmacist. Infection control, team lain yang buat. Okay. With that, I thank you. Thank you. Tak ada soalan, terima kasih.
Jadi keputusan Hanim merangsang saja ada beberapa komen. Yeah, no lah, just comment because Shan Hanim mentioned a lot of guidelines. I agree. I just talked to Dato' Rosman. Guideline for me, guideline can only apply if you have a diagnosis. A lot of time, you follow guideline, but your diagnosis is wrong, it equal to non-judicious juga. Example, I cerita tadi, infective endocarditis, dia ada pulmonary infiltrate, all that is because of pulmonary hemorrhage because of overwaterinization. Tetapi bila you hantar report kepada Shan Hanim, you kata hospital acquired pneumonia, grow Acinetobacter pulmonale, and you want to start polymyxin. Appropriate mah, follow guideline mah, hospital acquired pneumonia mah. Tapi kalau you tengok balik CRP 5, procalcitonin 0.1. Tapi X-ray teruk. Yang ini appropriate ke not appropriate, Dr. Shan Hanim? So sometimes we have to, this is where I prefer feedback and audit. I will debate with the surgeon lah. Kena debate lah ini. Kena debate because we have to call a stop somewhere. Because there's the one comment I will say that all of us need to be responsible to come to a correct diagnosis. incorrect diagnosis, even though you follow guideline, it becomes inappropriate usage. We have to be responsible and accountable for our diagnosis. Second, don't think that nurses are no role in antibiotic stewardship. Nurses also play an important role in antibiotic stewardship. Why? Siapa yang collect urine culture? Saya collect ke? Masa junior saya kena, saya houseman saya pernah collect urine culture lah. Sekarang saya collect pun boleh, tetapi you tengok berapa doktor yang collect urine culture. Doktor main order aja. Lepas itu siapa collect? Nurses kan? Kalau nurses collect urine culture daripada urine bag and hantar kepada microbiologist, kita panggil rubbish in, rubbish out. Urine culture grow Acinetobacter baumannii. And then you clinician guna spinal reflex, kasih start antibiotic. Tetapi ini kebanyakannya berlaku kepada paraplegic patient. And also patient yang ada, yang immobilized, yang ada CBD. So I always tell my junior, do not simply order the nurse doing urine culture, and urine culture has to collect appropriately. Kalau patient on CBD, you tak boleh collect urine culture from the bag, you kena buat in-out catheter. Kalau patient ada three-way, yang urology patient, banyak, ni sana ada satu, yang itu you kena collect in an aseptic technique kalau you nak collect daripada any tube. So collection of specimen is by nurses. So nurses play an important role in antibiotic stewardship. Siapa yang ada buat wound swab, orthopedic, Dr. Shan Hanim kata orthopedic banyak apa. I'm not defense orthopedic or apa. A lot of time, kalau you suruh patient potong kaki, siapa suka potong kaki? Tak ada siapa yang suka potong kaki. Semua puji Dr. Leong kasih antibiotik. Bolehlah selamatkan you punya kaki. Tetapi bila ada diabetic foot, macam mana you collect swab, wound swab culture pula. Ini yang banyak dibuat oleh kita punya, I tidak menyalahkan nurses, tetapi nurses diarahkan oleh doktor untuk collect specimen. So buatlah wound swab. You wound swab saya punya kulit, you wound swab saya punya hidung, mungkin you dapat MRSA juga. Lepas itu you nak kasih vancomycin. That is also so specimen collection need to be appropriately done in order for it to be meaningful to interpret. Yang apa lagi? Yang microbiology has to be selective in reporting. Sometimes, example, I'm not sure other microbiologists dekat sini lah. Microbiologist role is also very important because when you report antibiotic sensitivity, you tak boleh keluarkan semua daripada you punya apa yang you dapat tu. I give example, kalau you dapat Enterobacter, takkanlah you tulis sensitive to ceftriaxone, sensitive to ceftazidime, sensitive to semua you. Sebab Enterobacter cloacae is a MC chromosomal induced resistant. So you kena selektif untuk keluarkan seperti ciprofloxacin, itu saja. So you kena selective reporting. Kalau you tak selective reporting, the clinician who are not so aware of the how the antibiotic work will use a non-judicious antibiotic. Apa lagi? Ya, Dr. Shan Hanim sudah mengiklan dan promosikan KKM punya PPS, which is going on from 1st of December sampai 14th of December. Bila kita buat, I suka buat PPS ini actually. Sebab macam I actually menghayati PPS ini penting. Sebab as Dr. Shan Hanim mention, PPS ini penting. Tetapi bila kita menginterpretasikan PPS ini, kenapa kita punya nosocomial infection, data yang di-collect oleh infection control, dia tak tally dengan penggunaan antibiotik. Penggunaan antibiotik melampau, tetapi nosocomial infection cantik lah. hospital Kuala Lumpur nosocomial infection sikit aja. Sebab kita takut orang penalize kita kalau hospital Kuala Lumpur jadi champion in nosocomial infection. Siapa berani datang hospital Kuala Lumpur? So bila kita buat point prevalence study, kita kena ada training. Macam Dr. Shan Hanim kata, ada training. I rasa a lot of sebab itu saya mengalu-alukan sometimes ago, I am actually suggest kita buat PPS untuk pharmacy, kita kena buat PPS untuk nosocomial infection bersama. Sebab pharmacy dia pandai tau. Dia tengok semua patient antibiotik yang dia collect data. Tetapi ada antibiotik yang digunakan diagnosis dia nosocomial infection, Pak kata dia tak ada nosocomial infection. Tetapi dia tak ada nosocomial infection. Tetapi kenapa dia pakai seperti kapapina pula? Kebanyakannya patient macam ini sama ada dia punya diagnosis kita tak tahu. Diagnosis dia sepsis. Tapi sepsis dari mana? Tak tahu. Sebab patient fever. So pakailah. Tapi kalau you investigate, maybe it's endocarditis, maybe it's spine abscess, maybe some collection tak tahu, maybe it's lymphoma pula. Sebab itu saya kata kita kena more aggressive dapatkan diagnosis yang sebenarnya. Kalau tidak, PPS akan dia jadi tak tally. Sebab empirical treatment kebanyakannya disebabkan tidak ada diagnosis. So masa kita buat ini, masa kita analyze data ini, kita akan faham kenapa kita punya penggunaan antibiotik ada yang inappropriate. Dia berpunca daripada sini. And macam Dr. Shan Hanim kata, nosocomial infection, dia punya kriteria ketat sangat. So sometimes, if you discuss with the clinician, and the clinician mati-mata kata dia ada nosocomial infection, tapi tidak fulfill criteria, mana nak letak patient ini ya? Tak tahu. Ada banyak. So it's good. I will promote that kalau hospital Tengku Mizan nak join, kita join and kita bincang. Ada banyak loophole yang kita boleh belajar. I feel that ada segelintir. I don't know. We should carry on with our study and see. Kalau kita buat bersama-sama, kita kena analyze patient yang ada penggunaan antibiotik, tetapi nosocomial infection itu tidak ada.
Sebenarnya isu yang PPS 2018 tu ada kesilapan yang dibuat oleh infection control team. Dia tak include semua patient antibiotik. Dia tengok fever saja. So fever is not a good indicator. So Dr. Syed dah bising lah pasal ni. So kan lagu bersama sebentar kan.
It's good to gaduh so that kita tahu kita punya kesilapan, kita belajar dari kesilapan.
So this time around, kalau satu perusahaan nak buat, dapatkan this antibiotik dari pharmacy, yang itu audit saja. Baru betul. Kalau ikut fever susah. Fever faham je kan. So the one of the reason why our HAI very underreported is because they use fever all this one. Selama-lamanya, dari zaman dulu.
And fever not equal to infection.
Yes.
Fever can be antibiotic induced, can be lymphoma.
Kapuski macam I. Sibuk ni. I kata, I nak tengok semua antibiotik. So kata, Dr. Syed propose, since pharmacy doesn't use antibiotic, give that data to infection control to audit the same patient. Yang 2018 menata pun sama. So kita nak buat yang betul-betul kan. Dia ni dah bertahun-tahun tak berjuang, tak ada effect apa pun.
So we have to promote.
Dia tak nak kena final data ni cakap kan. So semua hype bawah kapet.
A lot of things kita tak boleh hide bawah kapet because kita kena honest, and dengan honesty baru kita boleh berjaya kan. Ini terutama askar-askar ajar kita semua honest kan. And this one is we need to be honest and we shouldn't be shamed because we are fighting against the germs. Kita kena bersatu padu untuk melawan kuman. kuman sudah lebih pandai daripada kita. Kalau tidak, memang bahaya kita tak ada antibiotik lagi.
If you have a idea of surveillance, so there is different, right, from surveillance criteria and clinical surveillance criteria. So I think maybe the miscommunication or
Yeah, agree. Yeah, agree. That's why we have debate masa kita buat training juga, bila kita tetapkan kriteria nosocomial infection. I agree with you. Sometimes the patient the criteria is not being fulfilled, but the clinician love our patient. Kita semua love our patient. Walaupun kriteria tak fulfill, dia rasa dia nak start juga. So in this scenario, that's why this is some loophole that I don't have an answer, Shanani. Sometimes in this scenario, I will still follow the clinician, even though I lose, because we need to capture the data. Kalau tidak, the data will lost. And that's how Shanani said that penggunaan antibiotik banyak, tetapi nosocomial infection cantik, because walaupun tak fulfill criteria, maybe we have another column. And Shanani, next meeting is a good suggestion. We have another column where the criteria is not being fulfilled, but the clinician insists that this is the diagnosis. So we can know what is the discrepancy, because because we have to agree that we are not Tuhan. Sometimes we have to buy in our clinician. I tak boleh kata, oh kalau tak fulfill criteria, patient mati you boleh pasang. Cannot, because there are also medical legal issue behind also.
That's why what I suggested at the national level, denominator will be based on antibiotic. Okay, so kalau katakan based on antibiotic ada 10. And JCI audit confirm nosocomial infection 3. So this data, 30% of patient on antibiotic is having nosocomial infection. So maybe yang another 7 tu committed acquired, right?
Actually yang tengah-tengah itu yang macam ini lah, dia ada banyak sebab.
That's why kita dapatkan yang ni dulu. Lepas dah dapat data tu baru kita boleh buat Zoom audit. Sebab PPS juga semua itu dia nak Zoom. Lepas tu kena ada satu lagi audit.
Yang audit kan yang tak tally, yang tak tally.
Yes.
Because yang tak tally ini ada banyak sebab. Yang tak tally ini kadang-kadang disebabkan kriteria tak fulfill. Ada juga yang bukan kriteria. Yang kriteria tak fulfill mungkin disebabkan dia ada diagnosis lain. Diagnosis kita mungkin silap. Yang kita kena ada masa. It's because this is a point prevalence study.
So thank you for Dr. Leong and Dr. Shani for the great discussion. So we would like to invite Major Rizawati Binti Mokhtar to give her speech regarding antibiotic usage and antibiotic resistance. Please welcome.
Assalamualaikum warahmatullahi wabarakatuh and very good morning. My name is Major Rizawati. Okay, I'm from pharmacy department. Today I would like to present about antibiotic usage in this hospital and also antibiotic resistant pattern. So for the first part, antibiotic usage in Tongkumizan, there's 18 injectable antibiotics from 6 antibiotic groups that included in the monitoring, which is cephalosporin, carbapenem, polypeptide, quinolones, penicillin plus beta-lactamase inhibitor and also glucopeptide. All the data were submitted to Bahagian Amalan dan Perkembangan Pharmacy KKM for national surveillance on antimicrobial utilization. So this is the pattern of total antibiotic utilization from 2016 to 2021. Okay, this one is for hospital tranquilization data. Di sini we can see that there is increasing total antibiotic utilization for all wards in 2021 compared to 2020. The data for 2021 is from January to September, but there's decreasing trend for total antibiotic utilization for ICU. For cephalosporin utilization, you can see that in 2020, hospital tranquilization was listed in top 5 hospitals with highest cephalosporin utilization in ICU. But in this year, we can see that is increasing trend in wards, but decreasing trend in ICU. For carbapenem utilization, in 2020, tranquilization was listed in top 5 hospitals with highest carbapenem utilization in ICU. But for this year, we can see there's increasing trend in wards, but decreasing trend in ICU. For polypeptide utilization, we only have colistin. We see increasing trend in both in wards and also ICU for this year. For fluoroquinolone utilization, tranquilization was listed in top 5 hospitals with highest fluoroquinolone in all wards in 2020. But in this year, we also can see there's increasing trend for fluoroquinolone utilization in wards, but there's a non-fluoroquinolone utilization in ICU. For vancomycin utilization, we can see that hospital tranquilization were listed again in top 5 hospitals with highest vancomycin utilization in ICU. But this year you can see increasing trend in wards, but there's decreasing trend in ICU. For piperacillin and tazobactam utilization, there's also increasing trend in ward, but decreasing trend in ICU for this year. So, on behalf of lab department, I will present an antibiotic resistant pattern. For gram-positive organism, you can see there is a resistant pattern for oxacillin, and same goes to MRSA resistant pattern. For gram-negative organism, Acinetobacter baumannii, there is increasing resistant pattern for unacin, ampicillin sulbactam, piperacillin, ceftazidime, ceftriaxone, cefotaxime, cefepime, imipenem, meropenem, and meropenem. For MDRO, Acinetobacter baumannii resistant pattern, you can see the resistance is still for imipenem and also meropenem. For E. coli resistant pattern, you can see there is increased resistant pattern. For E. coli resistant pattern, you can see there is increasing trend for ampicillin sulbactam resistant, and also for cefuroxime, ceftriaxone, and also ciprofloxacin. For ESBL, there is resistant for ceftazidime, ceftriaxone, cefotaxime, and increasing resistant pattern for cefepime and also ciprofloxacin. For Klebsiella pneumonia, you can see there is increasing pattern for augmentin, unacin, tazocin, cefuroxime, ceftazidime, ceftriaxone, cefotaxime, cefepime, imipenem, meropenem, and also ciprofloxacin. And for ESBL, we can see increasing trend for resistant pattern for unacin, tazocin, almost all cephalosporin, and also ciprofloxacin. So in conclusion, in 2021, you see there is an increasing trend for utilization antibiotic in wards such as cephalosporin, carbapenem, fluoroquinolone, vancomycin, piperacillin, tazobactam, and also colistin. In ICU, we can see there is increasing trend for piperacillin, tazobactam, and also colistin. And for antibiotic resistant pattern, we can see that there's increasing trend for drug resistance for Acinetobacter, for unacin, cephalosporin, carbapenem, and also ciprofloxacin. For MDRO, Acinetobacter, there's increasing trend for carbapenem. E. coli, there's increasing trend for unacin, cephalosporin, ciprofloxacin. For ESBL E. coli, there is increasing trend for cephalosporin and also ciprofloxacin. And Klebsiella pneumonia, there's increasing trend for augmentin, unacin, cephalosporin, and also cefepime. And lastly, ESBL Klebsiella, there's increasing trend for unacin, cephalosporin, and also ciprofloxacin. And that's all from me. Thank you.
Thank you for Major Nolizawati for the presentation. So next, I would like to invite Major Dr. Nur Aziah binti Kasim untuk for her presentation for case discussion. Thank you.
Assalamualaikum and good morning, Datuk CEO, Dr. Leong, Ms. Sharifah and tuan-tuan and puan-puan. So actually, I will present this case presentation regarding the related is our topic today with the scenario for this patient, how we treat this for the CRD. So this Mr. A, the 75 years old gentleman, as serviceman, as chronic smoker for 25 years with underlying hypertension, only the one antihypertensive. Actually, he completed 2 dose vaccine, last second dose on the 19th of the June, and he presented to our ED. Actually, we treated, noted the RTK antigen positive with the symptomatic. So this admission. Actually, I'm managing one patient transfer in the ICU for this patient. So initial presentation, this patient presented during day 4 illness when he presented with a fever, cough for 4 days with a shortness of breath for the past 1 day. And initially, there's a required the nasal form oxygen 3 liter with the blood cell initially 12 with the neutrophil lymphocyte ratio for 135 with the absolute lymphocyte count is a 2, and the CRP very high at the time, so we treated as a COVID-19 pneumonia, Cat4. We started with the dexamethasone in view of the requirement of oxygen 3 liter, and we start with the IV augmentin and also for the vaccine. So this patient is a chest X-ray initial presentation. You can see the consolidation involve the both lower zone and also involve the mid zone. Initially, this patient was admitted to our disaster medical zone. So this we give the summarize for this admission. Initially, when he admitted on the day 4 admission with the high CIP, we cover with the dexamethasone and augmentin. And we start a progression. We noted on the day 6, required the face mask 5 liter with slightly AKI. So we at the time we maintain the dexamethasone. However, on the day 7 of illness, he started deteriorated. So at the time we required the high for mask 50 liter. So noted slightly reduced CRP and also the at the time we given the dexamethasone 20 mg OD with the escalate to IV tazocin. Unfortunately, there is no blood culture was taken at the time. Okay, so on the date 8 admission, there's a progression, required a high flow nasal cannula with the slightly static impacting markers, and at the time, because the requirement of the oxygen, so they changed to IV methylprednisolone to actually the body weight around 75 kilo. That's why they give to methylprednisolone 150 mg. Okay, on the day 10 admission, the CRP after the started the methylprednisolone is a reduction more than 50%. At the time, I think there's given the started the babiesitinib. So this patient was intubated on the day 12 illness and required the SMB node, FiO2 the 0.4 with the reduction of the CRP and noted is a worsening the metabolic acidosis. So this patient was intubated and transferred to the ICU COVID. At that time, there's a continued the babiesitinib and also the methylprednisolone. And it's transferred. So posting in the ICU admission, our ICU COVID, is a if there's a worsening the CRP, the impacting marker with the increasing the white cell count and also the worsening the AKI. However, at the time the PCT still low, and was the complete the methylprednisolone was stopped and then changed back to the dexamethasone 8 mg OD and just maintain the tajocin and also the complete the babiesitinib for the 5 days. The patient maintained the intubated with the requirement to maintain the saturation FiO2 with the 0.4. So the chest X-ray on the 23rd of August during intubation is quite similar. On the day 17, illness able to extubate this patient with the time noted there is a worsening the AKI and maintain the dexamethasone and also the continue the tajocin. Then on the we continue the same and on the day 18 at the time because the RT-PCR was was done and not detected, so this patient was transferred to GICU. So this is chest issue before the transfer to GICU, the general ICU. So on the noted on the day 22 admission at the time of 2nd September, this patient worsening the symptom patient with the re-intubated because the worsening the type 1 respiratory failure, and also this patient was hypotensive and required isotope support. So noted the worsening the metabolic acidosis and also this worsening of the AKI and also the impacting marker actually at the time was static. So this patient auditions with the prednisolone from the dexamethasone and escalate to IV meroquinone at the time, and also the repeat the blood culture, implicitly with the IV fluconazole, and then done the dialysis for the 6 hours. On the day 25 illness on the 5th September, this patient intubated, sedated, maintain the saturation of the ventilator setting with the BP at the time, we able to reduce the isotope support. And however, noted the impact marker was increasing on the day 4 meroquinone and with the high PCT. Then start the IV unacin 6 gram BD for the cover for the MDRO Acinetobacter. And this patient was planned for the tracheostomy on the 6th September. This on the 2nd September, during the patient be intubated. On the 7th September, noted at the time the slightly, actually the CRP quite improving at the time. We give the report for the blood culture is a comeback the Klebsiella pneumonia with the ESBL positive with CRE. But at the time we've seen the CRP is a reduction from the 300 to 137 with the PCT also reduction with the clinically so the improving we able to reduce the isotope support on the UNASI on the day 3 at the time we off the fluconazole and also off the meropenem because initially we didn't start the poly-E because in view of the clinically this patient improving with the impact marker also reduction. That's why we didn't start. But noted on the after the patient developed the next swelling after 6 hours then the tracheostomy. So proceed with the CT scan, noted this patient there's no hematoma. However, there's a pneumomediastinum and the subcutaneous impediments. I think this one possible cause why difficult to reduce the ventilator setting for this patient. So this result come back on the actually we sent the 3 September. This result actually after we start the meropenem on the day 2. There's a comeback at the Klebsiella pneumonia with the resistant to all antibiotic. There's a CRE, but at the time quite surprised because this patient very respond with the UNASI in view of the clinically improving and also there is a CRP improving and also the PCT. This is a blood this is a chest X-ray on the 6th September. So on the 10th September, on the day 29 illness, it's a worsening the CRP, but at the time this patient because regular dialysis and is on the central line, he developed a high grade temperature with chill and vigo during dialysis. And however, there's no any pulse on the central line. That's why we start the IV vancomycin to cover for the MRSA. And we refit the blood culture, central and peripheral line. So on the 13th of the September, the clinically usually this patient start improving, patient oblique command, we able to of the sedation and also can change to the NIV, ventilator by change to the NIV, diapet with the FiO2 0.6. We trace the blood culture at the time, the 7th September, the sample no go, but the fever come back at the Stenotrophomonas maltophilia with the sensitive to bacteria. So at the time we already UNASIN on the day 9, and because there's no suggestion for the MRSA that we off the vancomycin. Actually, we plan for the CTPA and HRCT, include the to look for the PE and also the OP. This state essay on the 13th September. So this result has come at the Stenotrophomonas. Naturally, this MW. So maintain on the 15th because clinically this patient otherwise issue on the unable to reduce the ventilation. So with the CRP slightly static, at the time we start 40E, we start with the 8 MU stat and the 2.5 the million unit PD with all the UNASIN and also the taper down the prednisolone every the 5 days. Okay. On the day 37, this patient, I think he developed the fast AF post HD after 2 hours dialysis with the drop PP at the time and required isotope support, and also they reduce the oxygen saturation and increase the FiO2 to the 1.0. Okay, the time on the day 4, IV polymycin because the fast AF given the IV ionidavone loading and maintenance. However, this patient was condition deteriorated. We increased ventilator support and also the isotope support and was asystole and with the cause of death post-COVID pneumonia with severe OP complicated with the severe sepsis. So I done my presentation. This is the latest this patient before the pass away.
Okay, go back to the first slide. This is where I find that the majority of our patients who presented with COVID, I wouldn't combine with antibiotic at the first line. So augmenting here, augmenting here is not indicated. Because when the patient is, this is where we talk about antibiotic stewardship. If you have a rapid test already confirmed with influenza or mycoplasma or coronavirus, we should not combine with antibiotic upfront. If you want to use antibiotic, it's to later when there is evidence of nosocomial infection. So I feel augmenting here is not necessary. My question to you is, this patient progressively getting worsened and CRP getting worsened. So it looked like he already go to cytokine storm, and rightly, you're escalated to without prednisolone and keeping parasitic, which is appropriate. That's why the patient finally improved, CRP come down. So my question, what is the, I'd like to know what is the justification? You all change the patient from augmentin to tazocin on day 7, 18th of August. Looking at the CRP is coming down. It's more likely that this patient is having cytokine storm rather than having nosocomial infection. It is day 7. Is it because, maybe you want to, anyone want to tell me
I think
why?
the one reason because this patient we admitted the DMZ, they support the 50 patient. Actually we admitted in the disaster medical zone. We got the 50 patient in the one area. So because of worsening the saturation, that's why we cover for the also one cover for the hospital acquired pneumonia.
50 patients.
In the DMZ, we got the
Is
disaster medical zone. The last time we opened the COVID ward is open. We got a lot of patient. So I think that's why we cover what.
Oh ya lah, saya the DMZ itu actually is a garden kan.
Garden, yeah, just
So
open
why
one.
not cover melanosis? Just joking. Instead of cover pseudomonas, which is
That is I think because they were with the oxygen.
I can see this kind of phobia. So I'm not expect you tell me that this is in a zone that you takut dia pergi. Same thing will happen in hospital Kuala Lumpur. I will say this is very. I will challenge whoever start tazocin here. I know the difficulty. I can feel. I can put myself in the shoes. When I'm a junior doctor, I probably will do the same. Because as a junior doctor, saya pun takut juga. Looking here, doktor yang pandai cakap aja. Sekarang I tua sudah, I pandai cakap aja lah. Patient oxygen requirement is increasing.
Yeah.
Patient is getting worsen. Berani ke you tak kasih antibiotic? Most of us will do that. And for stewardship, as we are working for stewardship now, if you are worried, I will say that if you are worried, you can do a procalcitonin here. Because procalcitonin negative predictive value is good. If procalcitonin is high, I takut have the debate go on because positive result doesn't mean infection, but difficult to interpret. But if it's low, I will say that we should.
Actually, we did
Like
after.
hospital Kuala Lumpur, because of the COVID, we start our service for PCT lah. Yeah, because kalau tidak, walaupun procalcitonin mahal, kena kira balik tazocin berapa mahal.
Betul. Actually, we send
Pharmacy.
after the 6 tazocin, just send the PCT.
So here I will say that now you finally you do a procalcitonin, it become very debatable. The procalcitonin is if anything more than 0.5, there is a probable already. So if you put down the procalcitonin 0.65, yeah, I still, if this is in my ward, I will not use because I see procalcitonin kalau betul infection will be more than much more than 0.65 lah. But this is arguable and we are at borderline. Yeah. Yeah,
actually
next time
we
we're talking about severe procalcitonin. Yeah.
actually we did at the day 25 and also we did the this one. We repeat with the PCT and also we repeat another the 3 times. Another one we repeat also on the this one on the day 26.
But when the patient intubated already, I will not only based on procalcitonin, I will also do a tracheal aspirate for culture.
We did the last, but it's a mixed pool. We sent, but it's a mixed pool. But the last.
After patient intubated, as Chan Hanim said, procalcitonin mahal, you do a tracheal aspirate. The tracheal aspirate negative predictive value is also high. And then you do a tracheal aspirate, you can see pus cell of a lot amount. If there is not much of pus cell and there is no growth, we will be confidently say that the likelihood of this patient having nosocomial infection is not high. But if there is a positive result, go back to clinical judgment. PCT high also have to rely on other parameters. We cannot base on the PCT high alone and jump on conclusion. So eventually he go blood culture.
ESBL.
Actually this one I will not put as a ESBL. I will just put as a CRE because it is resistant to imipenem. It is so it actually resistant to carbapenem. Meropenem also resistant. So this is already a CRE. If there is a blood growth CRE, is a disaster. Tracheal aspirate growth CRE, again, I will need to interpret whether that is a significant organism or not, because blood is a sterile site. Any organism grow at a sterile site is very difficult to ignore. So in this scenario, I will tend to treat the CRE Klebsiella. Just tengok balik you.
But the what's why the with the response on the UNASIN, with the clinically also improved at the time. With
so
the
you continue with UNASIN.
because the PCT also reduced, that's why we maintain the UNASIN. But after that, we.
But this is this Klebsiella is actually resistant to UNASIN. If it is resistant to UNASIN and still you use UNASIN, it underdosing already. Because it is a resistant, and if this is a resistant to UNASIN, you still want to use it for acetaminophen, I can understand. And you want to use a super high dose of sulfactam, but I'm not comfortable if it's resistant. If it's resistant, I will go for polymyxin already. This is a Klebsiella, this is not a acetaminophen. Yeah, Klebsiella resistant to UNASIN cannot use UNASIN anymore. I will jump to polymyxin B or polymyxin E. And the creatinine of this patient at this moment is?
He need actually regular dialysis lah. Because the worsening the creatinine with the regular dialysis. He did the ATM. So.
Yeah, this is not an end-stage renal failure.
No, actually AKI.
It's acute kidney injury. If acute kidney injury, I will use poly B. Poly B because it's less microtoxic. This is the bacteremia. And if in this scenario, I will also look at because the blood culture grow CRE, tracheal aspirate other CRE.
Actually, we send after that is mixed grow only.
mixed grow
mixed grow.
boleh discuss dengan microbiology lah. Kalau mixed grow, you have to run to the microbiology early because you see Klebsiella in the blood. So if you run to the microbiology early, then still have the specimen. I will ask them what is the predominant. Kadang-kadang kita kena correlate whether this is in the sexual experience or not. If yes, then it's in it probably from the primary source is from the lung. If not, then we have to look for line. The patient is on dialysis. What line he used for dialysis?
Go the central,
Sorry,
you go the femoral. You go the femoral, the right side. Femoral.
Yeah, femoral, we all know femoral line for dialysis is the common source of infection because nephrologists, if possible, should avoid femoral line. Femoral line is being used because it's convenient, but we shouldn't use femoral line for long for dialysis. It's only in emergency. After that, we should change to IJC. So whether you have done a culture from the femoral line and see whether it's grow the similar.
Actually, we did no grow. We did a central blood culture on the 7th. We did both lah, but there's no grow on the central line.
But on the 7th is already that ESBL grow what date?
This ESBL on the 3rd. Actually, on the day 2, I did meropenem at the time. And day 1, I did UNASI. Actually, but they come back after 3 days. On the 3rd September, when we start the deteriorated clinically on the 2nd September.
The vancomycin, yeah. If you already grow Klebsiella, then you should not use vancomycin. I think that's what. Yeah, you have to trust the microbiologist. A senior microbiologist will say, you don't trust my result, then why you send for the culture? So you should trust that the CRE is the culprit. The CRE is most likely from the line anyway. We should use polymyxin from upfront. Then after that, the sternotrophomonas grow in the peripheral line. So the sternotrophomonas grow because of selective pressure, because you use meropenem. So because of the meropenem, all the sensitive to meropenem will get killed. Then sternotrophomonas, actinobacter, and fungal will grow. So it's not surprised. But in this scenario, I will not start antifungal also because the factor experience doesn't have fungus. So yeah, misgrow doesn't mean fungus.
Only the urine CNS got the Candida albicans. Urine CNS.
Yeah. Urine,
but
then
we
you
off
have
the
to go for Candida spore.
but we send the fungus CNS no go, then we off the fungus. Initially become.
Eventually, the patient's particulate jump high. So he may have some component of the nosocomial infection for this patient. But at the end of the day, do you repeat the tracheal aspirate?
The last line and the mid go to the last culture on the 19th. I think the
so sebelum ini tak
ada, we never did this.
One thing clinicians have to understand is that even though a drug reported as susceptible by antibiotics, but penetration kadang tak sama dengan this lah. So macam satu polis penetration tu kan memang very poor. So that's why kalau pneumonia tapi kan memang dia ambil masa nak resolve pada polisi. Sebab polisi is quite lousy lah. So adalah orang praktis kalau doktor tanya macam maintain politik tapi ID nak in favor sebab dia tak sistem tapi nanti kita kan so like to make sure communication bagus dan kita kena pilih tempat yang penetrate dan selain dari satu sahaja kalau tak nanti effect dia outcome of treatment lah. Tadi Yunus saya nak komen tahu whether you are using high dose USC for MDRAB, dia punya target mesti dah expected. Kalau less than that, tapi itu pun tengok pada MSC kan. Kalau MSC tinggi sangat, sebenarnya masih dah tengok pada kondisi terus. Sebab itu pun tak boleh buat pakai dus MSC. Tapi sometimes doktor nak pakai juga sebabkan pakai kondisi. Sebab ini formula hati kan, dia nak try diesel, berguna juga lah. So, dosing kena tepat. Pseudomonas lah dia dosing dia. Dia kena orang ada pseudomonas dose, mediating dose, dan itu kena appropriate. Dan itu biasanya memang patutnya kena refer dekat medical lidah lah. Dia kena guna kan, saya tak boleh tak boleh guna lagi. Alright, okay. Itu saya tahu.
As Dr. Shanghani mentioned, in this scenario, CRE is one, I will use polymyxin E solution. It is unless it's a urine. If it's a urine, then I use polymyxin. The reason being the polymyxin E, polymyxin is concentrated to the urine. So we use poly E for urine CRE, but for blood and patient with renal impairment, I would rather use poly E because there is no prodrug. Poly E got prodrugs is more renal toxic. Poly B got no prodrugs.
They don't need to loading those.
Result dia quality kan. Dan kita kena tanya MR banyak pasal ni masa tu Dr. Nora Zahir tapi sebenarnya tak boleh extrapolate quality pada polisi ini. Dan sekarang nak isu polisi resistant tapi IMR tidak boleh detect. Jadi kena careful juga bila nak pakai ini. Sebab dia dalam bentuk selular tidak boleh yang jadi kan. Tapi masalah sekarang polisi dah besar. Saya tak ada soalan juga. Sebab orang yang pasal kan NDR semua bagi sungai. Tapi dah register. Dah habis. So tak usah pakai ini.
Ada nampak trend recommending usage prior to therapy like this referring to cases of therapy.
No, I think another patient now, in the ICU patient, before the tracheostomy already developed the MDR. I think it's after we see lah, after dialysis, all patient in the ICU started got the MDRO, the CRE. We worried are they related with the dialysis or the ICU, even in the ICU setting lah, before the tracheostomy. Already developed the CRE. Now quite a lot of patients in the ICU, we got the majority of patients now, our ICU patient.
Concern is whether we should give
Before the tracheostomy. Because the blood culture at the time, because this time the blood culture didn't come back before the tracheostomy, but the result CRE actually on the third before the tracheostomy. So he
I don't think tracheostomy require prophylactic antibiotic. No. So it's not from ENT. So yeah. So ini pharmacy kena audit lah.
okay, so thank you Dr. Leong, thank you.
Major Dr. Asia, for the case discussion. So next, I would like to continue this session with the Q&A session. We invite all level of staff to ask any question related with the presentation. So any question on the floor? Yes.
Hi, I'm Ms. Bugis. I'm interested with the beginning of this case that mentioned that patient was started on steroid, not necessarily to recover with antibiotic. But as we know, some clinicians or some doctors, we do cover maintenance start on steroid with antibiotic because we are thinking of patient might compromise. Is there any difference? Because we had patients when it comes to our ICU on the day 6 post-trauma spine with a C4 burst fracture. So patient was admitted in that hospital for 6 days, started with a hip crack and continued with dexamethasone because of spinal shock. And patient was increasing of oxygen in there from 2 liters to 5, and another power center is on 10 liters of oxygen. But the septic parameter was normal, and because of the increasing oxygen, and once arrived, we transferred to ICU and noted patient's increasing oxygen to bypass, and we decided to intubate. After we intubate, we noted that the patient is difficult of ventilation, and after we do wrong, the lung was full with pus. So we were thinking patient might acquire casualty from the evidence and steroid because of the compromise. Is there any difference if this patient was started with coverage of antibiotic earlier? Because the septic parameter was an increase, the nasoprom oxygen increasing, but it was mistaken because of the perineal palsy. So nobody was thinking of, because there's no fever, no normal. So this patient was now seen in ICU. The difficult part is from we started antibiotic now, especially the coming back fast of pseudomonas. Is there any role if this patient started early on antibiotic coverage?
Thank you. This is a very challenging question. Thank you. This is a very challenging question. I have being asked this kind of question by not anesthetists, by rheumatologists. Rheumatologist has asked me this question for a long time, and I debate dengan saya punya ID. I have also that's why I always tell Sharifah there is no right or wrong answer. If you ask me this question, yes, I have no doubt that nowadays we have using so much of steroid in COVID-19. We cannot avoid to see the incidence of nosocomial infection actually higher. And our surgeon, you can ask the cardiothoracic surgeon, we have more lung access nowadays because of this steroid use in COVID-19. But will the number of infection we see now justify for us to routinely use prophylactic antibiotic to cover before we give them steroid? That's the question. Correct? Then? Yeah. I have gone through all, I think it's a Google, now go Google, we have gone through a literature review. If you compare patient who has given prophylactic antibiotic before initiation of high dose methylprednisolone or any immunobiologic. The rheumatologists always ask me because they go and do urine culture before they start biology. And then refer IP, boleh kasih antibiotic to treat the urine culture or not? And this is asymptomatic bacteria. Similar question. Patient has asymptomatic bacteria. Should we cover and treat the bacteria before we give it without prednisolone or any biologic? If you treat them, the likelihood of them getting infection later will be lower, definitely. But without the price to pay, it's not without the price to pay. If they develop significant infection, it will become a resistant germ. So there is no right or wrong answer. If you ask me, it's still controversial, and if you ask any of the IT division, it's not recommended. That is my answer to that. So I will say that to be fair to the patient, we have to explain to the patient the risk and benefit. Yeah, if you want to give antibiotic cover, is there a role or not? Yes, you will get less likely having infection later. But if you have an infection later, you will become resistant. So it's controversial, and in IT and also any literature point of view, it's not recommended. Can I answer the question? Yeah. The number of infection, definitely we will see. The number of infection is getting, now we see more common having lung access and we need to refer to surgeon. No question about that, but the number of infection has not justified a recommendation to use prophylactic antibiotic prior to antibiotic.
Can I take one question? But, in response to that, if we saying that the numbers of patients that who benefits less compared to the time that we start the antibiotic, how about is there any role, from your point of view, is the surgical prophylaxis is contribute to the system? Because the surgical starts on before operation and after, but if we reflect back what your statement means that we also very ravishly give antibiotic for surgery, but the SSI rate is very low with the current technology and current sterility.
Yeah, that's a good. To answer that, I would say that surgical prophylaxis will never contribute to resistant organism if it follows Shanghai guidelines properly. Surgical prophylaxis following the guideline is to reduce the bacterial load during surgery, and it should be given for 1 or 2 doses during surgery, not extend beyond that. As long as you don't prolong the surgical prophylaxis, it should not bring to resistant organism. It shouldn't bring to resistant organism. I see the surgical prophylaxis bring to resistant organism is actually I see in my own eye. I saw somewhere. I don't want to mention where I saw. Shouldn't be mentioned. The example I give just now, even though it's surgical prophylaxis being prolonged, I won't say it's not because of the over-vapularization become chest, look like chest infection. So it will carry on the for antibiotic, and eventually the patient develop multi-resistant Acinetobacter. So when he has multi-resistant Acinetobacter, we use high dose uracil. As the guidelines say, we use high surfactant. And after 1 week, then you repeat the trachea aspirate again, it becomes dermatomonas. So you can see the change. The flora of the trachea being changed by the antibiotic if you use it for long. So from sensitivity, initially it becomes multi-resistant pseudomonas. Later, because the patient not responding, because the ventilator setting is not getting down, and the diagnosis actually is pulmonary hemorrhage, we do another trachea aspirate. it becomes terminal for 4 months. So it's actually the duration of the antibiotic that actually contribute to the season. If you use surgical prophylaxis for only 1-2 doses, or even if the surgery is prolonged, you can add on another doses. We hardly see it contribute to any resistant organism. As long as the short duration of antibiotic, actually I won't comment too much, because if you normally also the short duration 1-2 doses, usually it doesn't cause resistance.
And just to know the practice of restricting in prophylaxis, memang one of the things we can audit in BPS is surgical prophylaxis. So in our audit, we do find they do prolong it. So kalau prolong is not considered prophylaxis, kan doktor yang itu kalau macam treatment. So itulah macam preemptive dia suspected infection on board. They keep on to be infected. Itu yang I think boleh menyebabkan resistance tu.
Any question? So next, I will present thank you to all speaker and presenter. Before I humbly invite Brigadier General Dr. Rosman bin Abdul Rahman, Commanding Officer of Tengku Mizan Armed Forces Hospital, to deliver a few closing words. Without further ado, please.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Selamat pagi. I think we've had a morning which is good, full of discussion. It's very enlightening in the way we should be using antibiotics. Saya suka the fact that we have to use antibiotic with justification. Yeah. So far, our hospital has been spending a lot on antibiotics, not as much as Sungai Buloh, I'm sure, because Sungai Buloh is the reference center for infectious disease, partly, yeah. But we spend about 1 million to 2 million. Last year we spent 2 million, yeah. 1 million, 1.9. This year we spend so far short of 1 million, 900,000 plus on antibiotics. There are a lot of things raised just now by the speakers, Dr. Leong and Dr. Syamhanin. If I may recall, the requirement for kita punya auditing, which we will soon embark upon, this is very, very overdue. I've been harping on this since I was IG in BPK last time. We need to have this, yeah. But now, since kita berada di sini, semua orang excited dan determined nak melakukannya, it's good. So we have a team yang memang interested and dedicated to have this done. Yeah. So during the recent HIACC infection control, HIACC. Okay. Antibiotics dulu kan? Antibiotic, right? HIACC. We have decided a few things. Yeah, we have decided on a few things. Firstly, since it has taken us 2 years plus to decide on one guideline, and we have no guideline in this hospital. Yeah, so we have decided that for now, unless one department, like you said just now, wishes strongly to follow certain guidelines from Wyoming State or some Wollongong district in Wales or somewhere, we will use national antibiotic guidelines for now. Yeah, and I like the fact that Dr. Syamhanin cakap tadi, we will try to tailor it to our hospital, probably to Mizan saja, or maybe to all 3 hospitals in the armed forces. Kita juga sedar keperluan IT itu, because it's cannot be so it can be very burdensome to do it manually. So we have also in our team the IT and also the engineers, because certain things may be done by them that will help reduce antibiotic usage and whatnot. Other things that we want to do lepas ni, specimen collection, especially before we start antibiotics. This has been lacking, and the way partly because certain things which I not go into. But one thing that we noted is, especially for severely septic patients in kecemasan, we need to give antibiotics early, right, for the bundle. And we have to bring the culture bottles down from the wards. So with the agreement of everybody present that day, we have decided to have the bottles down in A&E so that we can have the specimen taken then before we start antibiotics. And like rightfully, as you said, not all patients who have fever needs to be started on antibiotics in A&E. Only those who are severely septic, we need the 1 hour. Within 1 hour we can give. It helps with the prognosis of the patients. But bukan semua. Demam saja bagi antibiotic, and then you will be using it injudiciously. And the communication is very important. I think that couldn't be stressed more than that. But it is lacking anywhere we go. Right? In most places, we are friends with this, but when it comes to professional things, it's difficult to comment on other people's management. But nevertheless, shouldn't stop us from having discussions on the management of patients. And the link doctors, who should be, the one who knows the case in and out, if possible, but thoroughly about the case. And the one linking with the other departments when they're referring is also very important. For that, we have decided that MOs will do the referrals. In this hospital, housemans are not doing the referrals anymore, especially to the other departments. And that is enforced. And preferably, if possible, within the departments, you refer to the pakar, especially during office hours. The shortcut way is to refer to the houseman or the other department, or the MO, because you think it's the easy way out lah. Just inform the case, and then they'll come and they'll clerk again, and they come to a different conclusion maybe, or agree with your conclusion. But to convey properly, especially the urgency, the requirement for their help in managing your patient, we need the MOs to refer. And I'm still thinking of whether to make referring to the pakar mandatory. Not to MOs, Pakar does not need to see the patient. Then he can send an MO to go see. But he gets the referrals. He decides on what to do and see, and he knows what's going on. Maybe we do it during office hours at first, not at night, but that should be the way we do things in this hospital in the future, hopefully, if possible. What else is there? So, and also we're embarking on our own AMS lah. Just like I said, overdue. Good luck, Dr. Shikin and team. I am willing to give them more power, including to call doctors to come for discussions. Certain time, and the doctors being called have to come. So they have this so-called power bestowed on them that they can. Rather than being there as the penasehat to some patients, you want to have certain things. If you want to make changes effective and with results at the end of the day. So with that, I thank you all for spending time this morning to be present here and also elsewhere. Joining this antimicrobial stewardship session. And I thank you, Dr. Leong Chilun and Dr. Shamhanim Adnan, for taking time from your busy schedules to be here this morning and sharing with us your experiences. A lot of things that you have done and we are picking up here and there to make sure we can do this, smoothly, at least. Less hiccups compared to what you've done. Yeah, you were offering Dr. Sham the national antibiotic training too. We will discuss nanti dengan the infection team and pharmacy whether we would like to join now. Okay, so boleh tengok recording je lah. Okay, bukan dalam Netflix tapi somewhere there kita akan boleh recording. Yeah, thank you so much for being here. Short notice. Thank you UKJ and the team for making this possible. So until we meet again, I think we have some generative for you. Yeah, thank you so much.
So I would like to invite Vision General Dr. Usman and accompanied by Vision General Dr. Sharifah to present a small gift for the presenter. We invite Dr. Leong. We invite Dr. Shahani. So with that, marks the ending of today's PCD. On behalf of all committee involved, it is with a great honor. I offer thank you to all speakers, participants, presenters for your cooperation throughout this event. We have prepared a few refreshments available at the back of the house. Wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh. Thank you all for the cooperation.